or EMS paramedic training that somebody has. So it is rare, but these patients are living out in our community. I do have a patient that I brought today at the end that will come up. He has his equipment, of course, attached to him, so we can kind of see what that setup looks like, so it's not just in the slide format. But what I'm going to talk about today, just as a side note, I don't have any financial disclosures. I don't work for any of these companies. I'm a nurse that just works for Sutter that helps take care of these patients once we implant these pumps. What I want to talk about today is a little bit about the etiology and prevalence of acute chronic heart failure. I'm going to talk about ventricular assist devices, indication for use, selection criteria, why these patients get these devices. We'll talk about device-specific external equipment overview and alarm troubleshooting, and then also rapid and focused assessment of the VAD patient. And I do have a couple EMS paramedic case studies at the end that I've experienced over the last 12 years that I've been taking care of this patient population. So there's a couple different kinds of heart failure out there that the AHA has identified. We have acute heart failure, which is that heart failure that comes on suddenly. So those are the patients that are calling 911 in acute cardiogenic shock. Often this is from like a bacterial, viral myocarditis that the patient's having, and they're needing rapid something rapidly done to help take care of this heart failure. So those are usually like our postpartum cardiomyopathies, these patients that have acute MIs. Those are the calls that you're used to seeing patients with acute heart failure. Then we have this chronic heart failure population, which often don't have to call 911, that they're seen chronically and managed by cardiologists over time. And then the AHA has this new classification, advanced heart failure. And the advanced heart failure is that chronic heart failure patient that is now no longer responding to all the things we have in our toolbox that keep that patient out of heart failure, and they need something more advanced offered to them, and that's like cardiac transplantation or ventricular assist device, and that's what we're going to talk about today. So just to give you a basic idea of the physiology of the structural changes that the heart goes through with end-stage cardiomyopathy is you have your normal left-sided chamber here with a good amount of myocardium heart muscle that looks nice and strong, and a decent sized chamber to fill with blood. Here with end-stage cardiomyopathy, you have this very dilated left side of the heart. This outer myocardial wall is very thin-walled, and so what happens is it no longer has the ability to stretch and rebound to provide that adequate blood flow out the aorta to the rest of the body. So that's why we call it pump failure, meaning the left side of the heart is failing and it's no longer able to provide the patient the perfusion that it needs to sustain life. So heart failure prevalence and incidence, this is pretty substantial in the United States. About 5.7 million adults in the U.S. have heart failure. Heart failure costs nationally, on average, about $30.7 billion per year to treat, and those are the patients that you're responding calls to, bring them to the ED for chronic heart failure that are having heart failure exacerbations. About half those people who develop a heart failure usually die within 5 years of their diagnosis if they don't have the appropriate treatment applied to them. And then heart disease, including hypertension and stroke, remains the #1 cause of death in the United States. And that's really unfortunate because we have so many different things we can do to treat heart failure now, but not all the right patients get to the right centers at the right time. So just a quick overview of how heart failure is treated. I like this slide from the ACC and AHA that they put out in 2005. And this just gives us as clinicians a guideline of how to treat patients as they progress up this, what I call staircase with their heart failure progression. So we have the stage A patients. These are the patients that do not have heart failure, but I call it, they have the triple trifecta. They have hypertension, diabetes, and hyperlipidemia. So those are the patients that I know will have heart failure someday. They just don't have it yet. Then we have the stage B patients. These are the patients that are starting to have symptoms, structural changes, but no symptoms of heart failure yet. So we're starting to throw different medications at them to help prevent that heart from experiencing heart failure symptoms. Then they get up to stage C where they're starting to have heart failure symptoms, and we're doing different things to treat these symptoms like coronary artery bypass graft, open heart surgery to bypass grafts. We're doing percutaneous interventions to try to open up those arteries that are occluded. So these patients are getting different type of procedures to make them feel better. And then once all this fails, the patients end up at the top of the staircase, and then we're having to offer them some type of advanced support. So some patients we send home on IV drips like Primacor, dopamine, dobutamine. They go home and live with these drips with continuous infusion pumps. And then we get them primed and ready for the big day, which I call VAD and transplantation. So we get them all tuned up, is what we call it, on these drips at home, and then we do an advanced procedure like VAD and transplantation. Some patients do get to the point, though, where they are too sick to be able to offer one of these procedures to, and we do talk to them about palliative care or hospice care. That's an option at the top of that staircase. All right, so I just like to put this in perspective because I have a lot of people ask me, well, why don't you just get a heart transplantation? Why would you want a VAD with all this equipment that you have to manage? And I think if I had a choice, I'd probably want a transplantation if I had to choose. But the problem here over the last 2 decades, you can see the number of hearts that have been allocated in the United States has not changed since 1988. There's about 2,500 patients in the United States that get a heart transplantation per year, but there's about 25,000 patients that need a heart transplantation. So there's about 20,000 patients running around out there that if they don't have something offered to them, likely the AHA says they'll die within a year of that advanced heart failure diagnosis. So if this was my father, my loved one, myself, I would want a VAD if I had no other choice. So this is really the wave of the future. Is allocation of organs hasn't changed, and that's really because you guys do such a good job at saving people's lives. So talking about transplantation is a double-edged sword where you want the organs available for the people that need it, but also we want to help keep those people alive and not allow them to die. So this is the problem with all the great medical advances we've made, just the amount of organs available just aren't there anymore, so people don't get heart transplantations. So to put that all together, this shows since 2005 to the most current date that I can find the data for, the amount of patients in green that are being bridged with a VAD before transplantation has grown dramatically. So right here, there's about 50% of patients before they're transplanted here in the US have a ventricular assist device before that transplantation, because people are dying on the list waiting for heart transplantations because the organs aren't there. So unfortunately, I think what you guys are going to see is a lot of VAD patients, and I have 2 living in Carson City, 1 living here in Minden now, and there's probably more that I don't know about from other centers like Stanford and CPMC and UCSF. Probably have patients out here as well. So you're bound to start running into these patients throughout your career. So what is an LVAD? An LVAD stands for left ventricular assist device. This device is an implantable left-sided heart pump used to treat, not cure, end-stage cardiomyopathy, meaning that the patient's sick heart is still in their body, but what we're doing is we're treating their heart failure symptoms via a mechanical heart pump. So LVADs are traditionally implanted through open heart surgery. Unlike a pacemaker or defibrillator, the pump is powered by controlling batteries that live on the outside of the body, and the VAD acts as a bypass conduit for the weakened left ventricle, continuously pulls that blood from the left ventricle, propels and pushes that blood forward through the pump where it empties into the outflow graft suture to the ascending aorta. So there's different brands out on the market, different companies that manufacture these pumps, but for you guys and for your perspective, the way you interact with these patients is exactly the same no matter what brand they have. So they all have pumps that live inside of the body. The pumps all have an inflow cannula suture to the left ventricle that then pulls that blood out via an impeller that's inside the motor of the pump itself, pushes that blood out through the outflow graft that then dumps that out into the ascending aorta, and the ascending aorta then distributes the blood in its natural pathways. They all have drive lines that are tunneled underneath their subcutaneous tissue that exit the body, usually in the right lower quadrant, and then that's all connected to the external equipment, which is a computer that runs the operation. Those computers then always have 2 power sources attached to them that allow power to the pump inside the patient's body. So if I have my video work, this is cool. Half the time it works, half the time it doesn't. Oh yeah, there we go. So this gives you a visual perspective of that blood going through the inflow cannula, propelled through the propeller, and then, or impeller I should say for this device, and then out through the outflow graft. That's how the blood flows. And this is what the blood looks like going through the pump. And it has these different veins, if you will, veins on the pump itself that help to straighten out the blood as it's flowing through to decrease blood stagnation and thrombus formation. So ventricular assist device therapies, there's 2 different indications that patients can have these pumps for in the United States. I've talked a lot about transplantation. We have some patients that have these heart pumps as what we call a bridge to transplantation. Like I talked about, we have about 25 patients on support for that therapy. And then the United States also identifies this new category called destination therapy, meaning some of our patients have these implantable devices that give them a better quality of life for the rest of their natural life, and they're never going to be a transplant candidate candidate ever. So they're going to live their entire life with this pump until they die of a natural cause. We have about 66 patients. On average, we have about 90 patients running around in Northern California with these pumps. We have the largest center in Northern California with ongoing patients on support. Our longest standing patient on her original pump is 10 years. She reached 10 years this year. So for 10 years, she's been running on her pump and probably many more years to come. So they're not always transplant candidates. It just really depends, you guys. So for our implant data, just to give you an idea, we've done, it's over 300 now. This is a little bit old. We have about 30 HeartWare patients, which is the patient I brought here today has the HeartWare brand device. We have 16 HeartMate 3, which is a new fancy Cadillac pump on the market. And then all the rest of our patients are the HeartMate 2 patients. Our median years of survival post-implant is 5 years, which is pretty good when the AHA said that those patients likely, if they didn't have an intervention, would die within a year. So that's pretty good survival rate for patients that had no choice. Our catchment area is really the greater Sacramento area. I have quite a few patients, about 10 living in the Redding area, a lot in Chico, a couple in Reno. We have a lot in the Bay Area, and then Stockton, Manteca, San Joaquin Valley is where most of our patients reside. So we'll get right into talking about the devices themselves. So the two main companies are Abbott and Medtronic that make these devices. Abbott makes the HeartMate 2 and 3 device. Medtronic makes the HeartWare device. And like I told you guys, for you guys interacting with the patients, really it's no different no matter what brand they have. They all have a pump inside their body, and they all have equipment on the outside of their body. The HeartMate 3 is the newer, fancier pump on the market. Its design is a centrifugal type pump, much like the HeartWare device. It uses all the same external equipment that the HeartMate 2 device uses, which is nice for us interacting with the patient out in the community because they didn't put a whole different pump out there with a whole different set of external equipment accessories. So it's all the same stuff that the HeartMate 2 device uses in regards to the controller and the battery sources. The big upgrade that they made for us with the HeartMate 3 is one of the major risk factors over time is breakdown of that external driveline that lives on the outside of the world. The patient can break those wires, they can bend and fracture over time. So what they did was give us clinicians the ability to change the driveline by having a detachable portion. So right in clinic, I could give the patient a new driveline if they're having damage and alarms that are telling me that this warrants a driveline exchange. So that's a big upgrade that they made over this last 10 years with all the data we've collected for complications that patients have. This is what patients look like every day walking around the community. Patients have different ways of wearing their external equipment. The Abbott Corporation makes this holster vest. I call it the John Wayne. You have to be careful because it kind of looks like a gun holster, but it's just a patient's heart pump. So I had to do quite a bit of training with my security on campus because they really held up one of my patients like, put your arms up. He's like, it's my heart pump. So we're very hyper vigilant these days. So it looks like, you know, gun clip holders, but it's just the batteries that the patients carrying in their holster vest. And then they have their computer around a little fanny pack holder around their waist. This female patient has everything consolidated in a bag. It looks like a messenger bag, but you can see her driveline peeking out there that is then inside her body. The external equipment the patient goes home with, they go home with a lot of different things to be able to power their pump. The Abbott Corporation for the HeartMate gives them a power box, and they directly plug themselves into the wall at night to get constant AC power, so they're not sleeping with these clunky batteries on them and worrying about getting battery alarms. So they have an ability to plug into the wall at night, and it gives them a long 17-foot cord that they can connect to. And then during the day, they're on 2 batteries mobile walking around. All the batteries for both companies, when the patient locks and loads in the morning, last about 16 hours, so all day long before they have to change their batteries. The controller is something that the patient's connected to 100% of the time, and each brand has their own controller that's unique for their particular brand, and they both have chargers that allow them to recharge their batteries. They're lithium-ion batteries just like our cell phones, and they're rechargeable. Okay. The controllers for both devices, what I really like about the controllers and the upgrade they've made over the last about 5 to 7 years, is they all have these LCD screens that are interactive with the patient and the clinician. So what's nice about the interactive screen, if the patient has some type of alarm condition going on, it tells you what the problem is, what the action is right on the screen, rather than trying to have to guess what all the beeps and bongs and different lights mean. The Abbott Corporation, one of my favorite things is they have this green light on the front of their controller. So no matter what alarm is going off on this controller. If the green lights are on, you know for a fact that the patient's pump is pumping inside their body. So always think green is good, green is go. If you see a green light, you could take a deep breath and know that the pump inside the patient's body is pumping. The power connections look like this when the patient's up and mobile. They have their computer here that's attached to the drive line inside the body, and then the power sources are connected to these batteries that are connected to clips. So the clips allow that flow of electricity from the battery to the clip to the controller. For the hardware device, same idea. They have an LCD screen that interacts with you, that tells you if the patient is having an active alarm. It'll give you a message on there that you can read what the problem is, what the action is. For instance, if the patient doesn't have power, it'll say power disconnected, connect power. So it tells you right on the screen what the possible resolution to the alarm is. They also have power connections coming off of either side of the controller. So if you ever come in contact with a patient, they should always have 2 power sources connected. And this is their drive line that goes into the side of the controller. That should never be out of the side of the controller ever. And this is what their connections look like connected to their controller as they're walking around up and mobile throughout the day. So both the HeartMate and hardware controllers have software technology that's embedded inside the controller. The controller will provide you guys a way to work through the alarm condition. So when in doubt, always just read the controller and let it guide you through what could possibly be going on with the patient. All the alarms across the board, no matter what brand of pump that you are interacting with, they all work the same. They have red alarms that are constant screaming alarms. They're often flashing, sometimes not, but those are your emergent alarms. Those are the stop, we got to fix this right away. Then you have your advisory alarms, which are always yellow, soft broken beeps, sometimes flashing, sometimes not. So that's how all the alarms work, no matter what brand of pump that you're dealing with. Green is good, yellow is slow down, let's talk about it, don't freak out, red, stop, we have a big problem. That's how the alarms work. So when the patients go home, they do carry an emergency bag with them 100% of the time. My patient here in this community decided to change it up. He has this cool looking backpack, so just know that's the backpack that needs to stay with him. I usually issue a standard emergency bag that I train EMS paramedics in my community, but for him, he's using a different bag. But you'll notice every VAD patient that you ever encounter, if you do encounter one, should always have a bag that always has their backup information in it. Their backup information will have their alarm guide inside the bag that will help guide you what the different alarms could mean, what they sound like, and how to resolve those alarms. And each particular company has their own type of alarm guide. So the one for the patient living here in this community is the hardware device, and he has this paperwork inside his emergency bag along with his emergency equipment. That will give you an idea of what the different alarms look like and what you can do to resolve that alarm. The emergency bag usually looks like this, but look for something that looks like a backpack or a bag. Inside there, the patient has backup power sources. They have their EMS paramedic guide. They also have their emergency card that has our contact information. We have VAD coordinators on call 24 hours a day, 7 days a week. We have pager numbers and cell phone numbers that you guys can access to call us, and we get lots of calls from in the field to help equipment troubleshooting, and that's what we're there for. We always tell the caregiver to make sure they let us know, but sometimes in a panic, they're worried about their loved one and they don't always page us appropriately, so you guys could also page us or call us directly. So we do, inside the bags, have EMS instruction guides to be able to help guide you the best that we can in taking care of our patients, because they are a little bit different, and I'll talk about our emergency algorithm that the AHA has outlined for us. But inside for each particular brand, and the one that is the patient in your community, this is the one I have in the patient's bag that gives you an idea of what the controller looks like, what the circuit should look like connected. So if you see any of these things disconnected, reconnect them immediately. Tells you to grab this stuff if you see them in the house, bring it with the patient, because if you're going to transport them to Carson City Medical, I guarantee you they don't have any of this stuff there, and if the patient runs out of battery power, we're in big trouble. So I would like everyone to grab this stuff. I tell the caregiver to do that. It's not your responsibility, but this is all on the guide to help give you an idea of what you can do and what we need to pause and wait before we do. So it also has on here if the patient's having a red flashing triangle, which is the emergent alarm, we're wanting to make sure that you're looking at the controller. If it's telling you the pump is stopped, it guides you on what you can do in regards to ACLS algorithm, and I'll talk about that in the next slide. So this is just a one-page back and front, down and dirty, about the VAD patients in particular. Any questions about that? And I'm a fast talker, you guys. The only people that ever appreciate that are people in your field and in ICU. They love my lectures. So Notify us immediately if the patient's en route to a hospital, especially out here in these outlying facilities, because if they're going to Renown or Carson Tahoe, we need to get that patient out of that hospital immediately. They do not have the infrastructure to support our patients. They are not VAD trained on this level, so we will arrange with our transfer center getting that patient life flighted out to us immediately. So as soon as we know about it, we're on the phone, we're getting a septing doctor, and we're getting them out of that ED immediately, which the emergency room doctor there will appreciate, because they don't want to have to keep the patient there any longer than they have to as well. If you're unsure of who that patient belongs to and you can't find the emergency information, if you guys have our contact information, you can just get a hold of us. We know all the coordinators at these other centers. We all work together. We share care on a lot of patients. So you can give the patient's name, and likely I can find it in Epic and find that center for you, so you guys aren't doing that footwork. We can take care of that. But we will take a transfer of any VAD patient, no matter what program it is. It doesn't matter. They need to go to a VAD center, and that's the most important thing. So physical assessment of our patients is very difficult. So the biggest issue I have is assessing their blood pressure, because this is what their blood pressure looks like. So here's my demo pump running at 9,000 RPMs, and this is the patient's blood pressure continuously going through this mock tube here, so I can make a demo pump. So that makes it difficult. You're going to try to put an automatic blood pressure cuff on that, and you're going to get question mark, because it cannot read a blood pressure with an automatic cuff. If you do get an automatic cuff blood pressure, the study has shown about 70% of the time they're wrong by about 20 milligrams of mercury. So you'll get an automatic cuff pressure, but what does it mean to you? Not a lot. So really the best way to get a blood pressure is via Doppler. I know you guys probably don't have those on your rigs, so really what I recommend is trying to use your stethoscope and auscultate using a manual blood pressure cuff. So you'll just put your stethoscope over the brachial artery, you'll pump up that blood pressure cuff to about 120, bring it down. That first sound you hear is going to be the patient's mean average blood pressure, and that blood pressure will never go away. So that first sound you hear will sound like a wind tunnel, and then it'll sound like shh, and it'll never go away, because they have no diastolic blood pressure, because it's a continuous blood flow, and that's something hard to wrap our head around. So to be able to get a true blood pressure, you need to auscultate or use a Doppler, and that is what we call a mean blood pressure. They have one pressure that the body sees continuously for perfusion. They don't have systolic and diastolic anymore. And another issue we have is getting the patient's heart rate. Really the only way to get the patient's heart rate is to hook them up to a monitor. If you put the pulse oximeter on a patient, like I talk about in the next slide, the patient's aortic valve usually only opens every third or fourth beat. So if their aortic valve isn't opening every beat, what you're going to get is a pulse pressure of 35 to 40, but their heart rate's actually 80, because it's set by their permanent pacemaker that most of our patients have. So getting a pulse ox on our patients and a true heart rate off the pulse oximeter is usually quite incorrect, to make it more difficult for us to assess our patients. Sorry about that, I can't change that. So pulse oximeter has always been an issue, especially in the event of hypotension, hypovolemia. If the patient is negative in their fluid status, if their blood pressure is low, likely you will not get a pulse ox at all, or the patient's talking to you saying they don't feel very well, but it's 70. So you kind of have to go by those rudimentary assessment skills we remember way back when, where you're just talking to the patient, level of consciousness, skin color, pallor, those type of things to determine their oxygen status. So pump parameters. So the different pumps have controllers that I showed you that are attached to the patient 100% of the time. Those controllers have calculations that they provide for the patient's pump inside the body to give you an idea of what's happening to that pump and the blood flow in the patient's body. So one of the numbers that I find very effective for you guys to look at is the pump flow, and that really tells you how much cardiac output the patient gets, which I find more effective than just looking for the blood pressure and trying to get an automatic cuff pressure. And you can access the pump flow off of the patient's controller. For the HeartWare device, it reads it on the screen 100% of the time. For the HeartMate Abbott device, all you have to do is just hit the button that looks like a TV screen, and it'll bring up your pump parameters. Keep hitting that TV screen, and you'll see the patient has a flow of 7, which is a great cardiac output. So that's a good number to help guide you on how the patient's doing in regards to their blood flow. And just so you know, there's no button on these controllers that you guys can push that will hurt anything. So just start pushing buttons until you start seeing numbers. That's no problem. So they're meant for patients to live at home with, so you can't make changes at home, pump up your speed at home. So you can just push buttons on there. You won't do anything to harm the patient or change any settings. Feel free to just push until you get what you need. The speeds are the only number as providers that we have the ability to set. All these other numbers, you guys, are just calculated numbers that are calculated off an equation that the engineers plugged into those controllers. So the only number we manipulate is speed. The speed is a set speed that we get from our provider and set the controllers at. The HeartMate 2 runs the highest, 9,000 to 9,800 revolutions per minute, RPMs. HeartMate 3 is 52 to 58. Heartware is our lowest flowing pump at 2,400 to 3,000 RPMs. And this is just because they're different design pumps, axial versus centrifugal pumps. Power is the amount of power it's created to run that pump at that speed that we have it set at. So these are the numbers you have access to, and if you're having a question about a patient in the field, you could definitely access us and we can tell you, oh yeah, that's normal for the patient or that's not normal for the patient. So that's what we can be helpful in guiding you with, is regarding the equipment and then what's normal for the patient or what's not normal. So important clinical information, pump flow is not intuitive, you guys. It is a set fixed speed that we set. So it does not adjust to the patient's cardiac needs, for instance, with exercise or position changes. So one of the big complications we get is orthostatic hypotension, or the patient jumps up immediately and they get a syncopal episode. So that can be common in our patient population. The pump is very fluid sensitive. So you guys, this isn't a really in-depth design. This is a simple water pump. And just like a simple sump pump that you'd use to pump out, let's say your basement, same idea. It needs to be able to have a hose to pull volume into it. It needs to have a reservoir to empty that volume out into. That's all these pumps are. It's a very simple design. So what I say is they're very sensitive to having decreased volume in the patient's body, because what can happen is that pump is not smart. It's just going to continue to suck blood out of the LV whether the patient has it or not. And if the patient's very hypovolemic, what will happen is it'll suck down that LV like a pancake, and the patient will go into refractory VT, VF, and you won't be able to get them out of it. So almost always I say, if you're unsure about what's going on with the patient, give them a 250 saline bolus. You'll never hurt them with that, and the only thing you can do is probably help them. Most of our patients are anticoagulated, INR goal range 1.5 to 2.5. They're on Coumadin and aspirin, dual therapy. EKGs can be used to interpret rhythm and rate. They're really not good at helping you determine if the patient's having a heart attack or not. Most of our patients don't have traditional symptoms because they have this cardiac output provided by the heart pump. The heart's native heart rate really doesn't contribute to the patient's blood flow anymore, so their heart rate and their heart function doesn't really matter. And we also core out 30% of the left ventricle to stick this inflow cannula in there, so determining a true STEMI with a 12-lead EKG with our patients is almost impossible. You wouldn't be able to do it. That's something like a cardiologist has to tease out. So they also may be talking to you, walking and talking in VT or VF. I've had many patients come in torsades 350 talking to me saying, why won't this thing stop going off? And I have to put a magnet over it to get their ICD to stop shocking them. This is normal because the pump's still providing them plenty of cardiac output despite being in one of those lethal arrhythmias. Clinical contraindications, the hard nose for our patients, no MRIs, they can't submerge themselves in water, no vitamin K or acutely reversing their anticoagulation. That's not something you do on the rig, but those are parameters I put out to the community. Let's talk about some of the complications our patients have that you'll interact with. I'd say number one complication we get calls about are bleeding. The patients are on dual anticoagulation therapy, so we get a lot of just crazy nosebleeds where they're gushing out and they're calling 911 for it. GI bleeding, acute GI bleeding, to the point where we have you guys transport patients and their hemoglobins are 4. So really fast GI bleeding and traumas. So those are the number one complications we get. Those type of patients just need to be transferred to the closest facility. We need to try to get their blood volume stabilized, bleeding stabilized, and then get them to us immediately. Neurological dysfunction is another complication that's common with this therapy. You have your blood interacting with something that's not natural of your body. So developing clots or thrombus can be a potential side effect. So ischemic and hemorrhagic strokes are both issues we have with our patients. So we treat all signs and symptoms of stroke per protocol. Most of our patients take a daily aspirin, so you don't need to give them an aspirin because they've already taken one that day. Transfer them to the nearest stroke center that you guys are, your policy tells you to do so. TPA is something often we never give our patients. We've done it twice and did not have a good outcome with TPA. Most of our patients fall out of the bucket because they're on dual anticoagulation therapy anyways, and they don't meet the criteria for TPA. So most of these patients, if they're having an acute stroke, they need need to get to the local facility, and then we need to transfer them out immediately to us, because likely they'll need a neuro intervention, and that needs to happen at our hospital. Infection is another complication we have. VAD patients are high risk for infection because they have this portal from the outside world to the inside of their body. So we have patients calling 911 for acute sepsis issues, can't get out of bed, very high fevers, driveline drainage from the driveline, they haven't told us, and so they're calling you guys to bring them in. So all patients with suspected sepsis, just do per your protocol, give them volume, get them to the closest center. That's absolutely appropriate. So treat them like you would any other patient with sepsis. Device malfunction is another potential issue that has a really low incidence rate, about 5%. I do have a case study to talk about a device malfunction that I had out in the field. So if this ever happens, make sure you're getting a hold of us right away. We can help you guys troubleshoot that. RV failure and dysfunction is another common issue we have. This heart pumps on the left side of the body, providing anywhere from 3 to 7 liters of cardiac output to the body, but the right side is sitting out there kind of vulnerable, doesn't have any help, and it's just trying to keep up with that left side, putting all that cardiac output out that it wants, the left side wants it to. So often our patients can get in trouble with RV dysfunction, because remember, there's sick hearts still in their body. All we're doing is treating their heart failure symptoms with the left-sided heart pump. So with these patients, often they'll get in trouble. They get to the ED and they have to put them on inotropes like Primacor. So be cautious with these patients with rapid volume resuscitation, because the pumps are fluid sensitive, but if you dump a bunch of volume in them quickly, what you'll end up doing is put them in flash pulmonary edema, because their RVs will just punk out on you. So just be careful with that. I always say 250 bolus will never hurt them, but if you're slamming 500, you can quickly get them into RV failure. Okay, so just be cautious. Arrhythmias, you need to treat them per ACLS protocol. Most patients already have implantable pacemakers, ICDs in place. That's kind of the staircase I showed you. They had that at that stage D before they got to the top of the staircase. So for arrhythmias, if they have an ICD, great. The problem is sometimes they'll have a ventricular arrhythmia, and they're on all these different cardiac meds, and the ventricular arrhythmia is too slow. It's only 140. Their ICD is set to go off at 180. So they're too slow for it to be able to recognize, but the patient will start to have RV failure if that RV is in VT or potentially VF. So they may call you super short of breath. They're starting to pass out. 911 is initiated. You hook them up to the monitor and you see the patient's in a slow VT. Well, that's still a medical emergency. The RV is going to eventually give out. It can't stay in VT. So you can externally shock the patient if you need to, no problem. All the controllers are shielded from external defibrillation, so you can go ahead and put patches on. Try not to put the patches right over their ICD device, right? And then don't put it right over the driveline that you can actually feel and palpate in their abdomen. Try to avoid those areas, sandwich it front to back, and then you can shock them like you would any other patient. Chf exacerbation kind of goes along the line with RV dysfunction. These patients still require medical management of their heart failure. So if you're giving any type of meds, cardiac meds, starting to drip, dopamine, make sure we're doing an auscultated blood pressure and you're not doing an automated cuff, because you're not really treating the patient appropriately and not knowing if your therapies you're initiating are appropriate. So just make sure we're getting the correct blood pressure to know the patient's true perfusion pressure. And just to give you an idea of our complications, like I said, GI bleed is our #1 complication. We have about a 30% rate of incidence. Across the board, it's about 33% across the nation. Infection rate, we're about 15%, and neurological dysfunction about 11%. So these are our most common complications that we have. And like I said, the pump failure is only 5% incidence of failure, so that's rare. So #1 question I get these calls out in the field all the time. They're asking me if they should do CPR on an LVAD patient, and I really say my take-home message is treat them like you would any other patient is the key. I ask, please, let's pause. Let's make sure the pump is not running, because if the pump is running, why do you need to do CPR? You're never going to do better CPR than the pump can provide in cardiac output. If it's flowing at 5.5 liters per minute, you're never going to be able to do compressions at 5.5 liters per minute continuously, I guarantee you. I mean, maybe, but I doubt it. So if it's in an active alarm state, it's not running, the patient's apneic, unresponsive, they look blue and they're not talking to you, we'll get on the chest and do chest compressions. And this comes from the AHA. These these are their recommendations, and then start treating them per ACLS protocol, shock them, give them antiarrhythmics, everything else that we know how to do. So the AHA came out with this in 2017, and they said, you guys need to stop saying no CPR on MCS patients out in the field, because that's not the right thing to do. And for instance, I had a 19-year-old whose pump went down out in the field, and they did not do CPR on that 19-year-old, and they should have had CPR. So the AHA has seen this happen over the last 5 years and said, we need to give you guys out in the community some type of algorithm that looks like ACLS to give you an idea of how to approach these patients in one of these emergent situations. So all my local LIMSA contacts have adopted this, rolled this into their policies to help protect you guys out in the field and protect the patients. So what it's saying is, you're coming across a patient, they've activated 911, the patient's non-responsive, we're looking at their skin temperature and color and their cap refill. Do they look like they're having perfusion? Do they look blue? Do they look pink? We're looking at that right away. Do they have adequate perfusion? If they don't, well, let's look and listen for alarms. Is that controller attached to the patient actually attached? Is it alarming? And then I want somebody to get their stethoscope and listen over the heart area of the patient's heart. I don't care what that controller is saying. Do we hear the mechanical hum of the pump? Because when you listen to the patient's heart, you can't hear their heart. All you hear is this mechanical hum of the pump, and it sounds like hmm. So we're listening over the patient's heart. If we hear the heart pumping, we know the pump is pumping. If you hear the heart tones and no heart pump, then the pump's not pumping. So we determine, is the VAD functioning? Yes or no? If you did not hear that heart pumping, then we're looking at all this external equipment, and we're saying, is the driveline in fact attached to the patient's controller? Yes. Does the patient actually have power attached to them? Yes or no? So we're looking at all that external equipment, and then what we're doing is asking someone to change this controller, because the patient lives at home with a backup controller that they carry with them in their emergency bag 100% of the time. I require the patient's caregiver and the patient to be very proficient at changing this. But I will tell you, I've had several medics in the field do it with me over the phone, and I'm asking them to change the controller because the patient's blue, not responsive. What are we going to do to hurt them by changing the controller? Nothing. The only thing we can do is potentially save their lives. So we change all the external equipment on the outside of the patient. So did we get the VAD restarted by doing that? Yes or no? If we did, great. Follow your EMS, ACLS protocol, get them to the closest center. If we did not get that VAD restarted, somebody's on the chest doing CPR, because we know from all the studies the HA has put out that the only way a patient can thrive post-code is cerebral perfusion. If we're not providing it, the pump's not providing it, then even if the patient survives, they won't thrive post-code, and we haven't done our job. So that's what the AHA has lined out for us. They gave you guys some criteria here to determine if the patient has adequate perfusion or not. So they're wanting you to check to see to make sure the MAP's greater than 50 and PET CO2 greater than 20. So those are some hard parameters the AHA gave you guys to determine if the patient's having adequate perfusion. And if they don't meet those parameters, we're on the chest doing CPR, even if the VAD is functioning. Even if the VAD's functioning, but the patient's blue and they're not oxygenating, well, we got to do that then. We got to put in an airway, we got to give them CPR until we get them to the closest center. And we shouldn't have to call in to get permissions from physicians to do this. We should be able to do this just as clinicians in the field. And that was the problem. We had medics calling into the local ED that were not VAD trained, asking if they should do CPR, when we should be able to do this ourselves just by assessing a patient. If they're blue and they're not responsive, well, what does that matter? Don't worry about the pump inside the patient's body. Worry about perfusion. That's the key. So on-call coordinators, we have a couple of us on call. I've had issues with medics out in the field calling our pager number, and they're saying it's a non-working number, but it's a pager. So it goes beep, 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 enter your numerical message, and then you have to put in your phone number, and then we'll call you back right away. We carry that pager 100% of the time. The problem is after hours our answering service answers, and I imagine it's like a 19-year-old kid answering the phone. You're trying to explain to them what's going on, and they're like, okay, we'll page the doctor, we'll let you know. So if you want to get a hold of us right away, just call our pager and we'll call you back immediately. Within 30 seconds we return those calls. We have a huge team. We have a couple surgeons, cardiologists, infectious disease pulmonologists, full-time nurse practitioners, bunch of coordinators, and myself, the clinical educator. Any questions about that, you guys? Down and dirty, super fast. All right, here's a couple case studies for you and we'll be done. So the case of the honey do or don't list is what I call this one. So I had a 79-year-old male, status post 18 months, almost 2 years on his HeartMate 2 Lvad without complications. He's been doing great, running around, He's part of the Elk Lodge, driving, living his life. History of ischemic cardiomyopathy, BiV implanted ICD pacemaker, hypertension, hypothyroid diabetes type 2 is his history. Active lifestyle, including working in the yard, tending to his garden, attending church group meetings and functions. No recent hospitalization, no medical issues. 911 was activated on a Saturday afternoon by the patient's wife. The patient reported he was working in the yard all day long. Upon getting ready for bed while changing from the battery power to his power module cable, the patient received a continuous red heart alarm. We know the red heart is a bad alarm. Patient became lightheaded and was near syncopal during the alarm. 911 was currently en route. Patient's wife paged the on-call coordinator after she had initiated 911. We told her to change the patient's controller while you guys are en route. We said, let's get him off that controller, change his controller. We did that over the phone with her, confirmed the pump restarted. You guys arrived, transported the patient to us. And ED staff paged the on-call coordinator upon the patient's arrival. ED staff was instructed by us to leave the patient on batteries. I do not want them hooking them back up to the wall, because this is when this event happened, is when the patient connected to AC power. So the VAD coordinator, myself, I arrived to the ED within 30 minutes. I interrogated the heart pump. I connected them to our fancy monitor, looked through all the patient's data, saw the patient's pump did turn off, it stopped. Gross examination of the patient's drive line was completed. And after all this data that I collected, what do we think could be happening with this patient? Could he have a driveline fracture causing an electrical issue with the patient's controller? Maybe pump failure due to a pump clot or thrombus? Or maybe dehydration from working in the yard all day long? What do we think? First one? Yeah, okay. Pump failure, maybe has a clot and it stopped? I know, this is so hard. Dehydration, he's worked in the yard all day, he said. So maybe dehydration. This is what I saw when I got there. I was like, oh man, what'd you do? So I saw this as soon as I got there and did his interrogation, and found that he did in fact accidentally clip his driveline when he was doing his yard work throughout the day. So what I had to do is call out my engineers to be able to look at his driveline to see if we can repair this. So what he did was actually damage one of his wires inside his driveline, but thank God that there's 3 primary wires, 3 redundant wires. So he broke one of his redundant wires, but one of his primary wires, but he had a redundant one there that still allowed the pump to run. So we did a workup, confirmed the alarm condition was from an external driveline fracture. What happened was he connected himself to the wall and it shorted out his pump, because when you connect to the wall, it grounds out. So this gets into the real electrical engineering portion of these pumps, and that's why it's helpful to have us on call to be able to troubleshoot that with you guys and tell them, get them off that wall source, get them on batteries, keep them on batteries, because the pump will run on batteries. So what happened is it grounded out when they grounded to the AC power, and it restarted when the patient went to batteries. So we were able to do an external driveline exchange, and the patient went home the next day, no problem, completely survived that event without an issue, even though their pump had stopped twice on the interrogation. So that was the perfect marriage between EMS, paramedics, the family members, and ED. And the local ED was not a VAD trained center, but I talked to the paramedics on the phone. They got permission to bypass that center and bring the patient to us, which was the right thing for the patient. So this next one is Saga, the sick heart. We had a 36-year-old male, 12 months on his HeartMate 2 support, non-ischemic dilated cardiomyopathy with a familial history. History of remote substance abuse about 5 years ago, sustained VT episodes with BiV ICD implant prior to his Lvad. His last echo is TTE, noted he had a really large dilated LV. 8.2 centimeters is huge. Normal would be like 2 to 3, so this is a huge LV. Despite his Lvad being at optimal speed, so we have him cranked all the way up, but his LV is still dilated. So this patient has a sick heart. Recent hospital admissions for decompensated heart failure. He was going into RV failure on and off. We had to bring him in the hospital, put him on an IV Bumex strip, dry him out. He has a past medical history of non-compliance, but he's been pretty compliant the last 12 months. He's not been feeling good, so he's been trying to stay on board with what we tell him to do. So 911 was activated by the patient due to his ICD shocks delivered from the patient's ICD that's implanted. He got a total of 8 shocks. Patient is alert, responsive, asymptomatic when EMS arrives to the scene. His LVAD parameters look good. His speed's 9,000. His flow's 3.5. That's not bad. His power's 5. That all looks good for the patient. Blood pressure by automatic cuff was 80/50, so they were able to get an automatic cuff on this patient, which is rare. They didn't have a Doppler. So assessment, he's diaphoretic. He reports feeling of his heart beating out of his chest, like racing out of control. So what complications could explain why this patient received multiple ICD shocks? Hypovolemia anemia because we diuresed him, electrical imbalance due to aggressive diuretic therapy, or maybe increased cardiac irritability due to his large LV size. 3? Yeah, definitely 3. But all of them really. So it was really a combination of everything. That LV was big, we diuresed him, his potassium was really low, his MAG was 1 when he came into the ED, so it was all of them. So this is what we got when we brought him in, and this is what you guys got in the field. So he was in torsades, right about 300, and you guys gave him, EMS in the field gave him a 500 bolus, put some oxygen on him. EMS called into the ED, notifying them that they had a VAD patient en route. So patient arrived to the ED. I mean, initially what we did was we turned off his ICD because his internal ICD was not getting the patient out of the rhythm, and it had not terminated efforts at this point. The patient was given 2 grams of IV push mag. We initiated conscious sedation protocol, and we used a biphasic twice at 200 to try to get him out, and then we had to go to cath lab and get our old Bertha, the monophasic defibrillator, and shock him at 360 to get him out. So we ended up getting him out of that torsades finally, but what happened is we did a workup for this patient and found that his ICD generator didn't have enough joules to get him out, and also his LV was so large and dilated that that coil that was in there was not enough to be able to get the patient out, so they had to put a subcutaneous patch underneath the skin that would then, if the patient got defibrillated, distribute it to the whole bottom of the LV to try to shock him out. So their internal defibrillator just wasn't enough, and this was the patient's heart at transplant that we pulled out, and this was his new heart he got. So to give you an idea, this was what we were dealing with trying to shock, was this huge giant heart that was just on its last leg. Don't look at that, okay, back there for my patient. So that gives you perspective of what the patient needed and what the patient was dealing with. So if you want to come up here, Rob. So Rob just had his heart pump implanted on October 9th. So he's a couple months out, but man, he looks phenomenal. He's retired from Tahoe PD, and he is now looking forward to his transplantation in the future. But right now he's living with his VAD. So what he has is he has this brand, which is the heartwear device. And this one's a little bit loud when I hook it up, so I wanted to wait till the end to give you guys an idea. So for Rob, what he has going on is he has this controller that he wears around his waist. He has his 2 battery sources connected here, and then he has his drive line that is then coming out of his right lower quadrant that's attached to his controller all the time. The idea is, God willing, we'll never ever have to take this drive line out of the controller, because if it ever comes out, the pump abruptly stops. So hopefully we never have to do that, but what he does have at home with him is a backup controller that he knows how to change. His caregiver, I hate that word, but his loved one is Honey, knows how to change this as well. I check them off before they're allowed to leave the hospital, so they know the algorithm to change that out. And it's really simple, just pulling out the drive line and then putting the drive line into the new controller, hooking it up to power is the simple algorithm. Do you have any questions for Rob in particular?
How do you feel?
100% better.
Yeah. Because what was happening to him before he got his pump was he was having a lot of VT and VF that his cardiologist found. Did you ever have to activate 911?
Yeah.
You did?
Yeah. I was down at Les Schwab last year, and I went down and they had to take me up to Carson Tahoe.
Mm-hmm. So these are the patients that you're interacting with that are having arrhythmias because they have that big sick heart. The heart's dilated, it's sick, and it's not responding well to medical therapy anymore. So they're activating 911, coming to the hospital frequently, and he is lucky enough, his cardiologist saw these signs and symptoms and said, you need to get to a center right away. You need to be evaluated for transplantation and VAD because you need something to protect you. And he still has issues with those arrhythmias off and on. We have him on medications. He has an implantable ICD, but what's nice now is he's not going to pass out at Les Schwab anymore. He's going to be like, I don't feel so great. Maybe I need to call somebody, but he's not going to pass out anymore because the VAD now will provide him the support that he needs. And for our patients, we often put their ICDs at a higher level because we don't want them getting shocked for every VT episode. But we do monitor their heart rate when they come to clinic, and with his particular device, I have the ability to hook him up to our fancy monitor, and our fancy monitor gives us waveforms, and those waveforms tell us what his heart rate is because it's the blood flow through his heart pump throughout the cardiac cycle. So if he has 120 coming across the page, I know that he's probably in VTAC. So we check him and we see him at least once a month. He comes all the way down to Sacramento so we can interrogate his device, make sure he's doing well. But these are the type of patients that end up landing on our door, the ones that are calling you guys for these acute episodes. Yeah.
When your ICD goes off, can you feel it?
I did not, because I passed out prior,
Okay.
but everybody around me knew it went off because my whole body just jumped.
Okay.
But I never felt it.
And has it gone off on sense or
No.
since,
No.
Yeah.
Have you had a problem with this setup? Any kind of issue?
It causes lots of bruising, and it's not really comfortable. I found at nighttime, I disconnect it and lay it next to me, I sleep better.
Yeah.
Because this is the power line here, and there's enough slack in it that I can roll a little bit.
Yeah.
And so,
No mechanical issues?
oh no, nothing at all like that.
Did you experience any infection with it?
I experienced an infection, but it was a small intestine infection. None with this. When, and that was some other issues. When I have to change well, I don't have to change. My caregiver does. When she has to change this, we set up a sterile situation where gloves, masks, the hoodie. I shower. She showers me. I can't even shower by myself. I have to hold the bag up out of the water. She does all the cleaning. Then I lay on the bed, make it all sterile in the room. Kids are gone, and take it off, clean everything, and put it all back on.
That's often?
About every 3 days.
So not every day.
Yeah.
Yeah, it's a lot. It's a give and take, right? You know, he could barely walk, but feet without gross shortness of breath and having ventricular arrhythmias. Now he gets his life back, but there's a trade-off, right? There's no perfect world out there. So there's a lot that you have to do to maintain this pump. But man, what it does is really give the patient the gift of life. And what we have found, patients that are bridging now with VADs to transplantation do way better with their transplant, because before, patients were in his situation before, listing them for transplant, came in with elevated kidney function, their lungs are wet, they have pulmonary edema, and then we're putting them through a transplant, so they get pneumonia, they're on dialysis post-transplant. Now he's gonna come in with a total normal kidney function, normal liver, looking great, nutrition status perfect. Our patients are out of the hospital post-transplant 7 days. They get transplanted and they go home in 7 days because they do so well, because now they're a well person getting a transplant, not a sick person getting a transplant. So that's the difference in the payoff I find. It's not perfect, you have to have your honey take a shower with you. There's worse things in the world. Come on.
From start to finish, a shower is 2 hours minimum.
Yeah.
Just touching this area, getting it sealed off, then the shower, and then the cleanup afterwards. So, yeah, it's not I usually spend about 5 minutes just standing there. I can take a shower from it.
Yeah.
If we go on like you per se, and we have a known GI bleed, and he's having issues with like syncopal episodes, we know they're hypovolemic. I know you said to be cautious with fluid bolusing. Are we still caught if we know they're hemorrhaging inside their abdomen? Are we still doing just a 250 bolus, or can we be more aggressive if we know?
Right. You have to, cost-benefit ratio. I mean, if he's going syncopal on you, you have to give volume to resuscitate. For him in particular, his RV is really symptomatic. So he's on our highest dose of sildenafil. We use sildenafil, which is Viagra, high doses to treat RV dysfunction, because it dilates the pulmonary vascular is what it does. So it helps decrease that pressure off the pulmonary vascular system so the RV doesn't have to work so hard. So because of that, rapid volume will probably put his RV in failure. But if the patient has no circulating volume, what are you going to do? They'll have to protect his airway and deal with that later.
Okay.
Yeah, exactly. So I really say as a rule of thumb, you can treat these patients like you would any other patient. That's the rule of thumb. Just treat them like you would any other patient. Worry less about the VAD and worry about the patient.
Okay.
You know, I feel like people don't want to do things because they have a VAD, and what we do is don't do the right thing for the patient when we should have just treat them like any other patient. There's rare an instance where you have to fall out of that bucket, but I just kind of give you these tools in the back of your head to be cautious, knowing that, okay, their RVs are, you know, symptomatic because it was that sick heart in there, but that left side heart pump was helping the left side. But remember that huge heart, that RV is going to go out if you start slamming volume in that heart, and I know that. But what are you going to do if the patient's bleeding out? So just kind of keep that stuff in the back of your mind so that if you give a 250 bolus and they're feeling better, you're like, okay, I can back off. I'm almost at the center. I'll let them deal with it when they get there.
Okay.
Yeah.
With the center being in Sacramento,
I know.
just terrified or have direct?
My patient, yeah.
You find somebody directly to you?
Yeah, they fly all the patients to us, Carson City, Tahoe. I have a patient that their ICD kept going off. He was in refractory VT, and they just flew him to us. But you,
So they went through the medicine,
yeah.
Is it better to go through the ER or can we fly them directly? I mean, there's been instances where we've had burn patients who we've flown directly to the burn center.
Oh, really? For our patients, they usually want you to take them to Carson City, Tahoe. I guess that's the cardiac center here. So they go there, evaluate, and then we get them out of there as soon as possible to get them stabilized, because they can start them on antiarrhythmics, amio drips, all that stuff, get them stabilized, get the blood pressure stable, and then we get them flown out. So with our VAD-related issues, that's usually what happens in these outlying areas, Reading, that's how they treat our patients as well. They get them stabilized at Mercy and then fly them over. Yeah.
And if we find a Lvad patient, I know you said, follow the AHA guidelines for arrhythmias, but if he's in a stable VTAC, are we still gonna, our protocol for that is hanging amio drip if they're stable. Are we still doing that even though, if he's awake and talking, alert, good skin signs? Are we still treating with antiarrhythmics?
I guess that's something you can call in to see if you can do that.
Okay.
We're not physicians, we're just nurses, so we can't advise you on that. I'd say you have to operate on your protocol, but you can call in and say, hey, this patient's totally stable. Do you want me to wait until they get in and you evaluate them? Because you're right, I probably wouldn't at that moment if they're in a slow VT. And I've had patients in slow VT for days and they do fine.
Okay.
But the problem is eventually that RV will give out. So I guess call in to see if the cardiologist or the ED doctor, whoever's there, recommends you do so or you wait.
Okay.
Yeah. Yeah, good questions. Yeah. Any other questions, you guys?
I was a little confused on the right ventricular function.
Yeah.
Because I know this supports the left ventricle completely.
Yeah.
Is that pump dependent on the right ventricle being able to pump blood to the left ventricle?
Yeah, so that's how the heart works. So you have the left side that is the workhorse of the body that needs to generate all that pressure to get all the blood flow out to the aorta to the rest of your body. You have your right side, which is that low pressure system, but it needs to generate enough pressure to get over the pulmonary vasculature. Usually the cardiac outputs are pretty similar to each other. So if you have 5 liters pumping out of the left, the right's got to try to get that 5 liters over because that's what the pump's telling it to do. So it's trying to get 5 liters over through the lungs, oxygenated, dumped out into that LV so then it can go out the aortic valve. So what happens is sometimes those RVs punk out is what I call it is. It's trying to catch up and it's saying, okay, I can't do this. This is more than I can ask and I start doing this.
Yeah.
And when they go into VT, that RVs in VT, that cardiac output dramatically decreases on that right side, but does it decrease on the left? No, because that pump's pumping out at that set speed that we don't have the ability to change over the phone at that particular moment. So that left side is trying to put out 5 liters and you're only getting 1.5 liters out of the right. So then that right just gives up altogether and just starts rocking rather than beating, it just rocks. And it says, I'm out.
So if your right ventricle fails, the pump won't work.
Yeah, what happens is you're not having enough blood come over. So if you don't have enough blood coming over, what do you think is going to happen? It's hypovolemia on that left side and it's going to suck down because it's not a smart pump, you guys. It's not that smart. It just pulls out that RPMs we have set at, and it's going to keep pulling even though that RV now is getting more hypovolemic. And what happens is that velocity of that pull from that impeller sucks down that LV and then it's pancaked. And then try to shock that all day. You're never going to get a patient out of that. It's sucked down.
Yeah.
So it's getting hyperperfused. So that's why I say 250 bolus will never hurt. It can only help. if that's the situation. That's hard for you guys to assess when you don't see the patients all the time. But what you'll notice if you look at the controller and you're looking, for instance, on the RPMs, what you'll notice is the RPMs are going to be dropping down dramatically. So this one is at 2540. You'll see RPMs going down to 1,000 because it's sucking down. So it's trying to reach that speed we have it set at, but it can't because there's no volume in there. So if you see what we call speed drops and you communicate that over the phone to me, I'll tell you they're sucking down. I would give them volume until you get them to the center to get evaluated. So that's how you can use your controller more than all those assessment skills that you guys use with traditional patients, is use your controller to tell you what's happening. That tells you what's exactly happening to the patient's heart inside their body.
So if the RPMs are down and we find them in a lethal rhythm,
Volume.
symptomatic, bolus volume before we shock, because the heart.
I would do it all simultaneously. Make sure you have an IV in, start the volume, and then I would start shocking them if they're not out of that rhythm with their internal ICD. Is usually what EMS, how they treat our patients successfully.
The shocking won't work without the volume.
Yeah, especially if they're sucked down and you notice that their RPMs are dramatically down. Yes, shocking them won't help them get out of that if it's sucked down, because we have a mechanical problem here now.
Okay.
This is a whole different problem than just the patient's rhythm, is we have a mechanical problem because the pump's now working against the patient, not helping them. Yeah. Awesome questions. If you guys want to come up and look at these connections at all, you can. You can just come up and disconnect these, check them out. Thanks, Ron. So this is my, oh my God, so look at this, full circle.
I remember that. You were in the
So this is the HeartMate 2 pump. These tubes aren't in the patient's body. It's just so I can make it a circuit and actually circulate volume through it.
This is basically what I'm hearing.
And it's so loud, reverberating off the rib cage, you can't hear heart tones. All you hear is this mechanical hum of the pump. Exactly.
So they don't have shock is a big deal for these patients, right?
Yeah, for arrhythmias. Arrhythmias is a huge complication our patients have.
Well, just like shock in general, just being. Maybe not with this much insight because they're very voluminous. It sounds like they're volume dependent.
So what I say is they're preload dependent, afterload sensitive. So meaning preload dependent, they have to have volume come in, they have to have a reservoir they empty out into. So that's what afterload sensitivity is. So if you have a narrow area where it's trying to empty into, just like your sump pump, if you're going to have a lot of resistance, you're going to burn your pump out. Same idea with this. This is just a simple water pump, you guys. Nothing fancy behind it. So yeah, volume sensitivity.